Welcome to your meeting with ICM. The interpretation button should appear at the bottom of your screen, next to the Share Screen button. By clicking on the interpretation button, you can choose the language you would like to hear. The interpretation button will then transform this meeting into the selected language. To change the language you would like to hear again, follow the previous procedure by clicking on that same button. By default, you will hear the selected language at 80% volume and the original audio at 20% volume. If you would like to mute or unmute the original audio, click on the corresponding option within the language button. Enjoy your meeting. Bienvenue à votre réunion avec l'ICM. Comme la réunion propose une interprétation simultanée en français, le bouton Interprétation devrait apparaître en bas de votre écran à côté du bouton Partager l'écran. En cliquant sur le bouton Interprétation, vous pouvez choisir la langue que vous souhaitez entendre. Le bouton Interprétation se transforme alors en la langue sélectionnée. Pour changer à nouveau la langue que vous souhaitez entendre, suivez la procédure précédente en cliquant sur le même bouton. Par défaut, vous entendrez la langue sélectionnée à 80% de volume et l'audio original à 20% de volume. Si vous souhaitez couper ou supprimer l'audio original, cliquez sur l'option correspondante dans le bouton de la langue. Bonne réunión. Bienvenido a su reunión de la ICM. Como la reunión ofrece interpretación simultánea en español, el botón Interpretación debería aparecer en la parte inferior de su pantalla, junto al botón Compartir pantalla. Haciendo clic en el botón Interpretación, puede elegir el idioma que desea escuchar. El botón Interpretación cambia entonces al idioma seleccionado. Para volver a cambiar el idioma que desea escuchar, siga el procedimiento anterior pulsando el mismo botón. Por defecto, oirás el idioma seleccionado a un 80% de volumen y el audio original a un 20%. Si quieres silenciar o desilenciar el audio original, haz clic en la opción correspondiente del botón de idioma. Disfruta de su reunión.
Welcome, everyone. You can actively engage in this session through the chat box function. And for any questions you have, feel free to use the Q&A button in the bottom of your screen. We will address your questions in the end of this session. Now I'm going to hand over to Mandy.
Bienvenido.
Good morning, good afternoon, good evening, and welcome to number 4 of 5 of our webinar series. And today we're going to be talking about the cost effectiveness of midwife-led birth centres. Next slide, please. My name is Mandy Forrester, by the way. I'm the regulation advisor from the International Confederation of Midwives, and I was a member of the team working on this project. So just to let you know what we're going to be doing today, we're going to recap the earlier sessions of the series and consider where economic analysis fits with the wider project. I'll introduce our 2 speakers for today, and they will take us through the economic analysis, the background and the methodology, and also the findings of that analysis. And then at the end, we will have time for questions and answers. Next slide, please. So we've already done 3 sessions. This is number 4. And what we've discussed so far is that midwife-led birth centres exist in many low and middle income countries, and they can provide quality care when they're part of a well-functioning network of care. Now, we know that to be successful, MLBCs need to be tailored to the context that they're set in and to have an effective financing model, supportive and enabling leadership and governance, quality midwifery care that is recognised by the community, but also interdisciplinary and inter-facility collaboration, coordination and functional referral systems. Next slide, please. So we've been getting some great feedback from these sessions, from our first 3 sessions, and we really thank you for the active engagement and the messages that we've been getting and your questions. What we're going to do is analyse the questions that we've answered throughout the sessions, but also those that we haven't, and we're going to prepare a frequently asked questions document to share with you. And what's become clear is that you need resources and guidance to establish or strengthen MLBCs in your countries. Now, who supports, the World Health Organization supports midwife-led care in settings with strong midwifery programs, and at the moment a group of people are working on guidance that's forthcoming from WHO, and that's being actually developed by the Strategic and Technical Advisory Group of experts that look at the maternity side of WHO activity. And what we've really learned is that advocacy matters, and this economic analysis will support advocacy, because, you know, people listen to money, don't they? Money matters. Next slide, please. So why do we need an economic analysis? Well, evidence from high-income countries shows that midwife-led birth centres are cost-effective, but we don't know much about lower middle-income countries. And you'll recall that over the past 2 weeks, we've presented research findings from our 4 case study countries: Bangladesh, Pakistan, South Africa, and Uganda. And at this point, I just want to remind you about the country selection criteria. They had to be from a lower middle income country, have at least 4 MLBCs. And these MLBCs were either in the public sector or well integrated into the national health system. And lastly, the Midwives Association reported to us that data would be available and accessible for this economic analysis. So, in addition to the quantitative findings reported over the last 2 weeks, we collected quantitative data about the costs and outcomes at the selected MLBCs in our 4 case study countries. And it's this that we're going to share with you today. But first, let's have a look at a poll question and get some ideas about what you think about the costs of MLBCs. So poll question number 1. How expensive do you think midwife-led birth centres are compared to hospital settings? And you have several choices. So the first question is it more expensive? Is it less expensive? Is it about the same? Or don't you know? And that's really interesting. So what we're seeing is most people consider that midwife-led birth centres would be more cost-effective, less expensive than hospital-led care. So let's find out as we go through this morning. And our next question . What do you think the most expensive part of a midwife-led birth centre is? And we've got several options for you. Do you think it's midwife salaries? Is it other staff salaries? Is it facilitation, the facility and the operating costs? Is it consumables? Or don't you know? And again, look at that, that's very interesting. So over half, just over half, consider that the facility and the operation costs will be the most expensive part of having a midwife-led birth centre. Secondary to that would be the midwife salaries. So, as I say, we shall find out as we go through this morning's webinar. Next slide, please. Bruna mentioned at the beginning of the webinar about the use of the chat and the Q&A boxes. So if you're using the chat box, could you use that to introduce yourself and chat to other participants, comment on what you're hearing and share your own experiences? And could you use the Q&A box if you want to ask specific questions relating to the presentation? What we found in our previous webinars is that the questions sometimes go into the chat, and although we're monitoring the chat, it's quite easy to miss a really pertinent question. So please put those in the Q&A. And if you can ask questions in English, please do so, but we are watching the chat and the Q&A, and we will translate if we need to, so that the presenters can understand your questions and give you an answer. Next slide, please. So, without further ado, today's speakers are Dr. Vanessa Scarf from the Burnet Institute and Professor Emily Callender from the University of Technology, Sydney. And I'm going to hand over to Dr. Vanessa Scarf for her session now.
Good evening, everyone. It's lovely to have you all present with us this evening. It's evening in Sydney, where I'm located. I'm a senior lecturer in midwifery, and I've joined the project through the Burnet Institute. My own research interests are in place of birth. However, they've largely been related to high-income settings. So I was very pleased to be involved with this research, as I have a great interest in expanding MLBCs in all settings. And it has been an absolute pleasure to work with the large team of people who've been involved with this subject. So just by way of giving you some background, in high-income countries where an increasingly medicalised approach is common, MLBCs have been shown to be cost-effective, with Sustainable Development Goal targets that focus on reducing maternal and perinatal morbidity and mortality. Access to quality maternity care is essential. Facility-based birth in low and middle income countries has been the main strategy to improving these outcomes, and MLBCs could be a very good option. Maternity service challenges related to funding and resources, including staffing and training, can be significant barriers to upscaling access to high-quality maternity care. There is little evidence about the costs associated with the establishment and operation of MLBCs and the cost effectiveness compared to standard care. So our economic evaluation aimed to identify the operational costs for MLBCs in real-world low and middle income settings, and to estimate their cost effectiveness relative to current standard maternal care pathways in country. We gathered primary data for costs and health outcomes from 12 MLBCs in 3 countries, in Uganda, Pakistan, and Bangladesh. Gathering financial cost data proved challenging in all countries. In South Africa, we were unable to separate the specific MLBC costs from the general health system costs, so these were not included in our analysis. Most MLBCs, and that's 8 of the 12 sites in our study, were in the private sector, including for-profit and not-for-profit facilities. 2 sites were public-private partnerships, that is, public sector facilities supported by non-government organisations, and 2 sites were in the public sector. I'm going to hand over now to Professor Emily Callender, who will tell you about the methodology and the findings of our study.
Thank you, Vanessa. So I'm Emily, and I'm a health economist, and I work exclusively in maternal and women's health. So delighted to have been invited to be a part of this project with the study team. Next slide, please. So the aims of our research was to identify the costs and outcomes of MLBCs compared to standard care in each country. We wanted to identify the costs of running an MLBC, so looking at staff cost, facility cost, and transport costs, the costs of births in hospital facilities for both women who transferred out of an MLBC during labour, and also as a part of identifying the costs of standard care within each country. The outcomes of women giving birth in MLBCs and in standard care. Next slide. We initially worked closely with the national research teams to identify what types of costs they thought were relevant. We then designed a survey to be completed with the participating facilities to identify midwife salaries, other clinical staff salaries, other staff salaries such as cleaners, security and administration, training, facility rent purchase, operation costs such as electricity and water, equipment and consumables, and transport. And so we really do need to give a huge thanks to the national research teams who then worked hard to gather the typical annual operating costs in each of these three categories from each MLBC within each of the three countries. Annual costs were divided by the number of births in each MLBC to present a cost per birth. And it's important to note that we did not collect startup costs. We needed to identify costs of hospital births for women who were transferred out of MLBCs during labour, and also for our comparison group, which was women giving birth with standard care within each country. Costs of vaginal birth and caesarean section births were identified from previous studies that were published in the peer-reviewed literature for these study countries. We collected data on health outcomes at each facility. Health outcomes included hemorrhage, third or fourth degree tears or other serious morbidities, maternal mortality, stillbirth, and neonatal mortality. In order to combine these measures into a single metric, we applied disability adjusted life year weights, or DALYs, to each outcome. DALYs are a score between 0 and 1, which measure the amount of disability associated with the health state, with a score of 1 being equivalent to death and a score of 0 being disability-free or in perfect health. This scatter plot shows how each MLBC compares with standard care in each country. So there's a lot of information in this chart, so we'll explain each element separately. So the y-axis in red shows the difference in cost per woman between an MLBC and standard care in that country. If the MLBC is more expensive than standard care, it will be above the green line. MLBCs below the green line are less costly than standard care in that country. The x-axis in green compares health outcomes in terms of DALYs lost. So just a reminder that DALYs is the disability adjusted life years. MLBCs to the right of the red line have better health outcomes, and MLBCs falling to the left of the red line have poorer health outcomes. And so if we then look at this chart in terms of the 4 quadrants, MLBCs in the top left, or quadrant 1, are more costly with poorer health outcomes. MLBCs in the top right, quadrant 2, are more costly with better health outcomes. And this is quite common in healthcare for services to cost a bit more but produce better health outcomes for that cost. MLBCs in the bottom left, quadrant 3, are less costly with poorer health outcomes. And the best performing MLBCs in terms of having better health outcomes at a lower cost are in the bottom right quadrant, quadrant 4, which is shaded in green. And this is relatively unusual in healthcare, but is an optimal situation. So each MLBC was entered into the chart and identified by a colour and shape. So Bangladesh is shown in the triangle shapes, Pakistan in the diamond shaped, Uganda in circles. Private facilities are shown in blue, public shown in orange, and public-private partnership sites shown in grey. If we look first at Uganda, the 4 MLBCs studied in Uganda are shown in circles here. All 4 sites were private, so are coloured blue. So for example, Uganda Site 3 achieved better health outcomes at about the same cost as standard care in that country. Uganda Site 1 produced better health outcomes at a lower cost than standard care in that country. Bangladesh MLBCs are shown as triangles. Bangladesh Site 4 was private, so it is coloured blue. It achieved the same health outcomes but was more costly than standard care. Bangladesh Sites 1 and 2 were public, so are coloured orange. Bangladesh Site 3 was a public-private partnership, so is coloured grey. Each of these sites is in the green quadrant 4, which means they achieve better health outcomes at a lower cost than standard care in that country. Pakistan's sites are shown as diamonds. Overall, half the sites studied are in the green quadrant, achieving better health outcomes at lower cost than standard care in that country. Pakistan Site 1 also produced better health outcomes, but at a higher cost than standard care. This slide shows the breakdown of total costs into facility costs, which are shown in dark blue, midwife salaries, which are shown in orange, other staff salaries that are shown in yellow, and recruitment and training costs, which are shown in light blue. Annual operating costs per woman varied greatly, but midwife salaries and facility operation costs were consistent cost drivers in all countries. And there was no pattern between facility size and the cost per birth. Picking a few examples to walk through here, in Uganda Site 4, just over 40% of the costs were made up of facility running costs. Around 30% were made up of midwife staff salaries, and around 25% were made up of other staff salaries. In Pakistan Site 1, facility costs made up almost 80% of the total costs of operating the MLBC. In Bangladesh Site 2, midwife salaries made up around 60% of the total operating costs. So overall, MLBCs can offer better outcomes at a lower cost. 10 of 12 MLBCs, or 83%, demonstrated better health outcomes in terms of days lost compared with standard care in that country. 7 of 12 MLBCs, or 58%, demonstrated lower operating costs, so facility costs, staffing, training and recruitment, compared with the country standard. And 6 of 12 MLBCs in our study, or 50%, demonstrated both better health outcomes and lower operating costs. So I'm going to pass back to Vanessa now.
So we've just heard that MLBCs can be effective in any context. We identified MLBCs with lower costs and better health outcomes than country standard in all 3 countries studied, in private, public and public-private partnerships, in rural and urban settings, in large facilities, facilities that would have greater than 5,000 births per annum, and in smaller facilities that would have had less than 100 births. In freestanding MLBCs and those on site alongside referral facilities. Just remembering that on site MLBCs located near or on the campus of a hospital, as opposed to a freestanding MLBC, which is located outside a hospital. However, this study has a small sample size, and more research is needed to better understand the financing. Data collection is challenging, but really important to allow us to do this type of analysis, which supports advocacy. Thank you very much.
Thank you both very much for that. What I found interesting about that was that from the poll question, especially around which was the most expensive, we were right. So that was interesting to know. We have a couple of questions in the chat. So I'm just answering. So in addition to the interesting results on low-income countries, is there also data for high-income countries? And I'm going to hand over to Andrea, who's going to answer this question.
Thanks, Mandy. I actually clicked that by mistake, but I can answer the question. Possibly others might do better, but yes, not in this study is the answer, but there is plenty of data, which I think Vanessa's probably better placed to answer this than I am in terms of resources from high-income countries. Sorry about that.
No, that's fine. Thanks, Vanessa. Could I hand to you, please?
Sure thing. So there is some data to suggest that it is so birth essentially outside of a hospital is less costly, but there are interestingly similar issues with collecting the data and actually having it reported. So I did a systematic review a number of years ago now, which showed once we looked at all the studies that it's least expensive to have a baby at home, and it's then less expensive than hospital to have a baby in a birth centre. So the hospital facility, with all of the costs and infrastructure costs and staffing costs, etc., that come with giving birth in a hospital setting, make it more expensive.
Thank you very much. Another question that came into the chat actually was, do these outcomes have any relation to the size of the unit and the amount of births? And we think that Emily and Vanessa might like to comment on that one as well. So maybe Emily, perhaps you could give us your thoughts on that.
That was definitely something we were anticipating potentially seeing, something that we'd hypothesized would actually be seen, but we didn't actually see that coming through in the results. So there wasn't a clear relationship between the size of the facility and the costs of operating the facility, which was surprising. But again, it was a small sample, so it's hard to say conclusively that there is no relationship there.
Thank you. Vanessa, do you have anything to add to that?
No, thank you.
Thank you.
It's interesting though.
Yeah. I think we've got some very interesting questions coming through. We talked a little bit about advocacy. I mentioned that at the beginning of the session. And this question is asking which stakeholders support the initiation of MLUs other than ICM supporting governments through in-country, maybe midwives associations. And I wonder, as ICM, maybe I could answer that on behalf of what we do to support midwives associations. And I think that it's the advocacy that midwives associations can provide that's really, really important. So you really need to work with and through your midwives association to advocate for any changes that you want in your system. And we do have tools and toolkits and advice to support you do that. I wonder, Caroline, is there anything that you could add to that about the stakeholders?
Yeah, thank you very much, Mandy. Some fantastic questions this evening. And I think this has been a common theme throughout our webinars around how to change the views of governments, how to change the policy environment so that midwives can be supported. And for many of you, that's not only midwife-led birth centres, that's actually supporting midwives. So I think, as Mandy says, the ICM are doing a huge amount of work in this space, and your member associations in your countries can assist. We know now the WHO, the World Health Organization, has a recommendation from STAGE, which, as Mandy said, is the Scientific and Technical Advisory Group of Experts. I chair that group for WHO, and we have a recommendation from last year saying that countries should be supported to scale up the implementation of midwife-led birth centres. So we have it now in WHO. We also have it in all the WHO guidelines, the antenatal guidelines, the labour and birth guidelines, and the postnatal guidelines. All of them are saying midwifery-led continuity of care, and we know that one way to deliver that is in midwife-led birth centres. And we now have evidence, including the study that we're talking about tonight, and there are now 3 papers out of this study, and we hope to have the costing one soon. So I think you have to use the evidence, you have to use what you have, and you have to start and use your advocacy that you have. Sorry, a long answer to say there's lots of interest. So we're just encouraging people to have a start.
We've had another comment in the Q&A. It's disappeared. That's not right. Another question we had here is, are women covered by insurance in MLBC? And I think we covered this in the last webinar, where some women were and some women weren't. And I wonder if one of the researchers could maybe just clarify that point, please.
Yeah, I think that's right, Mandy. It very much depends on the individual country in question, and how well integrated the MLBC is within the broader national health system. So
yes,
it very much depends on the context is the only real answer we can give there, I think.
Yeah. I think that's absolutely right. And Benedicta Ekpos actually made another comment in the Q&A about asking about countries where midwife-led care is yet to be established and policies aren't made to establish its practice in the country, what can be done to promote its implementation. I think Caroline answered that really with what she was saying, and we can just reinforce that every country needs to have an enabling environment to allow midwives to work to their full scope of practice. And when we are working to our full scope of practice, that is when midwife-led care and midwife-led birth centres really are effective. So I think I can only reinforce what Caroline said, that to work through your MAs, to engage your stakeholders, and to really start advocating for changes within your health systems. We have another question here. If the salary in low-income countries and opportunity for advanced practices exposure increases, will there be an ultimate effect on improving care in maternity? So I think, Caroline, maybe you could pick that one up as well.
Mandy, just tell me it again. Sorry, I just missed it.
Sorry. It's about if we increase the salary in low-income countries and the opportunity for advanced practice exposure increases, I guess the question is the ultimate effect going to be on improving maternity care?
Yeah, it's a really interesting question, isn't it? And it goes down to you'll get better outcomes, but you have to spend more money in some cases. We've shown in this study that you actually don't have to spend a lot more money, and in some cases you will save money. But there's no doubt that if you pay your midwives where you didn't before, then you're going to have to spend more money. But we know the benefits of having quality midwives who are well educated in an enabling environment, and the research that Andrea and I did for State of the World Midwifery showing that we could save 4 million lives a year if you had quality midwives providing quality care, there's no doubt that you have to pay for that. It doesn't mean it's more expensive, but there is always a trade-off. But so it is tricky. I don't think we can pretend that quality care is free, because it isn't. But Emily might be able to jump in with the more economic response to that.
No, that was perfect, Caroline. I was really just wanting to support that by, if you think about examples from other areas of healthcare, so introducing new vaccines or new medication, of course, will also come with the cost, but that's cost is seen to be worthwhile or justified because it improves the health outcomes that are achieved. And so that really is, as I was explaining with the different quadrants, it's quite common in healthcare to see a new intervention costing more, but producing better health outcomes. And so it seems that the purchase almost of those health outcomes is worthwhile. And that's when we say something is cost effective. So just supporting what you're saying with that, because it is quite common.
Yeah.
There's another comment in the chat from Felicity Copeland, and Andrew's just typing an answer to it to her, but I think it's an issue that's come up through all of our webinars. What are the challenges from obstetricians who object or do not support MLBC, and how do midwives navigate this? And I think it's that's a wider discussion, isn't it, that we do need to have. We do need to we need obstetricians to champion MLBCs. We need them to support midwives in establishing them and working in them. But I think it's quite interesting to think about how do midwives navigate this? How do we navigate this relationship that can be quite difficult in some settings? I know, Andrew, you're typing an answer, but maybe you would like to just speak to that. Is that okay?
Yes, of course. Yeah, I mean, in the qualitative element of this study, that was highlighted as one of the key challenges that is evident in many settings. Both, and that the same has been found in high-income countries for studies there. It is a pervasive issue and a challenge, and that sort of professional hierarchy and that professional competition, if you like, is something that needs to be very carefully planned for and managed when establishing and running MLBCs. So some of the other panelists might have sort of practical suggestions about how to address that, but just to say that we will be talking about that a little bit more in our 5th and final session in 2 weeks' time when we look at the challenges. Sheila, do you want to come in there?
Yes, thank you very much. When I was speaking last week, I was saying that we have been fortunate in having a number of champions across the professional cadre for obstetricians and neonatologists. But that's very evident in the public sector. And there seems to be 2 different sets of power dynamics going on. One is the professional so-called hierarchy between obstetrics or doctors and midwives. But people who've been quite supportive while they have been within the public sector move into the private sector. And then there are other challenges that come their way. So, for example, trying to get medical professional practice insurance for private practitioners is often a barrier to them if they are going to have midwives that they are backing up. And there are a number of midwives who have been working for a number of years with backup from obstetricians who've had that withdrawn because the medical insurance companies have said that this is a risk factor and they'll put up their premiums or remove their premiums. So there's a huge economic factor as well. It's not just about professional hierarchies. I think professional hierarchies we really need to be addressing within the clinical space, within the teaching space, having cross-disciplinary teaching at undergraduate programs so that people really, value the midwives. And I'm very tired actually of hearing how many obstetricians say, oh, I've learned everything I know from midwives. But we actually want them to translate that into champion midwifery as well. But that other dynamic in the private sector is very strong and quite difficult to overcome without a huge groundswell with the medical insurance companies who clearly are not reading the literature and do not understand risk if they think that midwives are posing a risk to obstetricians' risk profile.
And again, the comments are coming through in the Q&A and in the chat. Obstetricians are our greatest challenge in Jamaica when it comes to MLBCs. However, midwives are continuing to do home birth, which is another challenge that that we face. One question here: which MLBC had a higher uptake of clients? Is it those with more cost or those that costed lower? So I don't know if Vanessa or Emily would be able to take that question.
I think that's sort of related to the costs associated with the size of the facility and so the number of births. And so no, we didn't really see that at all. That it was quite variable in terms of, I guess, the number of births and the cost per birth. Yeah,
no, thank you. I think we've sort of talked a little bit around this, and it will probably come up in our last one next week. But we have a question here: what strategies have been helpful? What have we found helpful to advocate with the government? And I don't know who would like to take that. Maybe Caroline, I think maybe I could ask you to give your thoughts about that one.
I can start. In my experience, governments are interested in saving money.
Yeah.
And they're interested in providing quality care. Some are less interested in that piece, of course, but certainly they're interested in saving money. So I think this study is really helpful in showing that you can get better outcomes for less cost or better outcomes for the same cost. What we don't have is prospective data, and that by that I mean data that you start today and you decide exactly what cost data you want to collect going forward. And I think we really need that. And as a maternity community, and those of you who are researchers or evaluators in the group, we really need to all decide what's the cost data we're going to collect, and we all collect the same. And so that we can then combine it and make studies like this really simple going forwards. So I think we need more data. So if you're a researcher out there and you're thinking about this, this is a fantastic area to study. And then we need to give it to our governments in ways they can understand. And I don't mean that disrespectfully, but I don't know any governments who are going to read a 20-page research report. They're going to read a 1-page policy brief. They want the 3-minute lift conversation. They want the high level, tell me how to solve the problem. And my experience of governments is they also want solutions. They don't want us going to them with a long list of more problems. We have to go with solutions. So translating the work that we do and the work that's available, and you can do that, into ways that your governments can understand. So I don't know if Emily's done a lot of work in this space around advocating to governments. She may have something to add here as well.
Again, just really supporting that being able to tell a story around cost savings is very compelling. So I think services and governments are definitely interested in where they can save money. If that produces quality health outcomes at the same time, that's also a nice news story. But also I think just being able to demonstrate where specifically the money is going to be saved it is also quite important. And also demonstrating that often those savings will be more immediate rather than sort of future cost savings as well, I think is also quite appealing.
Yeah, thank you both for those answers. I think for me, it's, as midwives, we need to become more invested in data, in understanding data, in collecting data, and we're all responsible for collecting data, whether that's when you fill out the birth register, when you fill out any polls and surveys that you're asked to complete. but actually having an understanding of data and how to use data is absolutely vital. And at ICM, we work with Direct Relief on the Global Midwives Hub. Now, with that Global Midwives Hub, you can actually produce a map of your country with the data visually on it. And I really would urge you to have a look at that. We'll get a link to the Global Hub up in the chat, if that's okay, Bruna. It's really, really helpful to show in real time and in a visual aid. As Caroline said, busy people lose interest very, very quickly because they've got so much to think about. So us as midwives, understanding data, understanding the power of data, because action actually follows that data, hopefully in many cases. So we can certainly help you develop some data to demonstrate to your governments. We've got some more questions here. Again,
on the basis of data.
Oh, sorry, I didn't see your hand. Do go ahead.
Just again, reflecting back on what was shared last week as well, I do want to really encourage people around data. We have a program in South Africa called the Perinatal Problem Identification Program. It was started years ago, and we just had 16 sentinel sites in the country. And as that was being presented at conferences, more and more people came on board, became champions. It extended and extended until it's now national policy that that data must be collected. That's one example. There's another example around our national confidential inquiry into maternal deaths and looking at where the good practices are happening in the country, so that now it becomes a national policy to roll out what we call midwife obstetric units, which include birthing and the whole continuum of pregnancy, as well as also pushing for on-site midwife birthing units, which would be on the same campus as a hospital, but separate. That now becomes national policy because the data has been collected. And it didn't start out as a, bells and whistles, huge national project. It started off with a few committed individuals looking for where the data could be generated. And it gained momentum. And we spoke across our professions at particular conferences, and then got the National Department of Health into those conferences. And then they heard the information and they had to be persuaded. So it really does. I mean, I know that we say data speaks, but we really, really have seen that happening. And I'm seeing a real possibility of this being escalated in our country. So I really encourage people, but there is more about that on webinar 3.
Thank you, Sheila. And Jen Stevens has actually made a comment that standardized financial data and outcome is being done in MLBCs in the US through something that sounds very similar in the American Association of Birth Centers perinatal data set. So people are beginning to collect, well, they are collecting this data, and it's there for us. It is there for us to access. We have another question that's come up. It's answered. Okay, that's fine. So I'm just looking at, in the context of the study, how difficult or easy is it for midwives to open or lead birth centres? And what's the best strategy to ensure that the centres are recognised? I think probably throughout the session we've been answering those questions, but was there anything that came up from the data that discussed how difficult or easy it was to be working in the centres? Maybe Andrea, I don't know if anything that you are aware of that came through.
Yes, and again, I think it very much varied by the context, but I would encourage people who are interested in this question to listen back to the recordings of sessions 2 and 3, which is where we discussed what was needed in order for this to happen successfully. So there does need to be supportive, enabling leadership and governance and structures in place in order for the centres will be recognised. In our study, we deliberately selected sites that were to a greater or lesser extent in that position. So because we were looking at trying to work out what was needed in order for this model of care to be operated successfully. So yeah, I think I could just, I don't know if Caroline or Sheila, you want to come in and expand on that.
Sorry, I'm typing another answer. I missed that.
It's the question about how easy or difficult is it for midwives to open or lead midwife-led birthing centres. And I was saying that, you know, we were talking about the success factors and the challenges in the last two sessions, but would you like to say anything about your experience there?
Well, I think it's completely different whether you're doing this in the public sector or the private sector. I think the private sector, one is really looking at, this is a business that is being opened. And so in South Africa, one has to comply with the necessary regulations around businesses, as well as the Department of Health's regulations for what needs to be in a particular facility and what policies need to be in place. At this time, any midwife who is qualified may open a private practice, but I think that there's going to be a fair amount of challenge on that in the next couple of years, that they would need to have an advanced qualification as an advanced midwife, as we call them in South Africa. But, you know, as I said, it is a business and it would need to be registered according to all the requirements from health and safety and economics and all the rest. Within the public sector, it would be an entirely different thing. And I think that would be, you know, negotiating within the practice space, as we did with a public-private partnership some years ago. And the things that they were most interested in was how much is it going to cost and how safe is this going to be. And when we said we don't want a new lift put in the building, they said you can have everything else you want. And when we showed them all of our clinical guidelines, they said we'd be happy if every practice in the country had this sort of level of detail. We feel confident that you can go with it. So one does have to, you know, do the due diligence to get there.
Thank you.
Yeah.
Caroline, you have your hand up as well. Thank
Yeah,
you.
just to add to that, I think in this study, and certainly I've heard at various meetings and conferences about the entrepreneurial midwives around the world. So in our study, particularly the midwives in Uganda, all the 4 sites we have in our study in Uganda were all private. They were quite entrepreneurial, which means they took opportunities and they set up businesses. We know there are entrepreneurial midwives in many countries. In my region, I can think of Indonesia, and I've visited midwife-led birth centres underneath midwives' homes in countries in my region. So I think there's lots of ways to do this. I think Sheila's right about following the guidelines and the rules and the regulations. You have to be safe. You have to be regulated in a safe and appropriate way. But there's no one way to do this. There are lots of different ways to do this. And we encourage you to think about, and we're going to talk more about this at our last webinar. So I'll just put a plug in that it's not next week. We're giving you a rest for a week. It's the week after. And we're going to really talk about actions that you can take. So I hope you come back to then.
Thanks, Caroline and Sheila. There was one question that came through in the chat, or a comment really, about a recommendation on which data should be collected, including the definitions and maybe some guidance about that data. And there isn't yet. It really is some work that needs to happen. I know from my own country, which is a high-income country, but standardising data really did help us look and understand about where we were, where harm was being caused. So it would be really, really valuable for standardized data to be collected across countries so that we really could do an accurate analysis of that. We've had a question about incorporating respectful maternity care, and I would urge you to listen back to our previous 2 webinars, because there were some fabulous examples, particularly from Pakistan, of women's views on the care that they received and how they valued being respected. So you'll find some more information if you listen back. Our webinars are all available. We've put the link in the chat, all available on there. They're on YouTube. You can listen back to them at your leisure. I wonder if any of the panelists have all got closing comments that they would like to make.
Mandy, if I may, I think I would just like to underline the point that you made at the beginning, which is this economic analysis is quite complicated and quite difficult, but it's absolutely vitally important for advocacy, because one of the early questions that we're always asked is, well, how much is it going to cost and can we afford it?
Yes.
So I think we need to really encourage as many people as possible to really engage with this data and this important research, because that will really help to counteract one of the common objections that we often hear.
Thank you, Andrea. And actually, what I would just like to thank our presenters for is that absolutely fantastic explanation of how to look at that data, taking it right back to just looking at the y-axis, etc. You know, it really made it very clear to me, and I hope to other people on our call, about the value of looking at that data, because you want to look at your area, don't you? You want to look at, where am I fitting into this? So it's absolutely vital that we understand how to use data. So as we've said, several of us have said on this webinar that we're back in 2 weeks' time, and that will be the 21st of November, same day, same time, but the 21st of November for our final session. And there we're going to be talking about scaling up the MLBC model of care in low and middle income countries. So much of our discussion today will feed into that. We will also be looking at the overview of the findings, the success factors and the challenges. And we've actually looked at an MLBC definition, so we will be discussing that, and we'll be taking you through a pathway to change that will support scaling up. So we really look forward to seeing you in 2 weeks' time, and thank you as ever for your attention and for your time this morning. We look forward to seeing you again.
Thanks, everyone. Bye-bye.
Thank you. Bye-bye.
See you in 2 weeks.
Bye. Thanks a lot.